Good evening. This is Dr. Lewis Foley, one of the ExamPro faculty, and we're going to go ahead and get started with our webinar for tonight, Tuesday, August 17th, 2021. Tonight, we're going to be doing a caseless defense webinar, and I'm just going to go ahead and go through the GoToWebinar control panel, which I believe that you would be familiar with, having been on our webinars before. But if you are new tonight, I want to just point out this is a slightly older appearing version of the control panel, but the controls are basically the same. The little orange box with a white arrow allows you to collapse or expand the control panel so you can get it out of your view during the webinar. The upper portion of the control panel determines how you will participate from an audio standpoint. By default, the software will likely pick your computer, microphone, and speakers. However, if you're in an area with a lot of background noise or you prefer to use a telephone, that's very easy to do. Simply click Use Telephone in the audio setup pane here, click Use Telephone, and you'll be given a number to dial in, an access code, and a PIN number. It is really important that you enter that access code and that PIN number so that you can be unmuted during the call. The next part of the control panel for typing in questions, we don't use that feature, so please don't type anything in there. I won't know that you did. But if you want to participate or ask a question, the best way to do that is to click the Raise a Hand feature, which is a little hand in a circle, and that will allow me to know that you're interested in either volunteering to be in the hot seat or that you have a question. All right, the last thing I will mention before we move on to the webinar is that our sessions are recorded. So if you have a need to get access to a recorded session, you can contact the ExamPro staff about how to do that. All right, I'm going to move on. Tonight, again, as I mentioned, is a caseless defense practice type of webinar. I show these slides anytime I give a caseless defense webinar. I'm going to make it very short tonight. The bottom line is that practice like it's real. You should gradually be able to work your way up to doing a 1-hour mock oral without any feedback or breaks. That's what you're going to be doing in Dallas. Once your list is finalized, which for some of you, you will have submitted your list this week. For others of you, you will be using the extra time for the late submission deadline. Whatever the case is, once you submit the list, only use the final copy, a version of the final copy that you submitted when you're doing mock orals, so that you will become more and more familiar with the cases as they're going to appear on the computer screen in Dallas. A bottom line is that your case list represents about half of the total exam content. They won't necessarily stick to your case list. They can change things, like you could have a 25-year-old with a particular problem, and they could ask, what if the patient was 55, and do little things like that. But again, practice with your case list, because half your exam will start from your case list. And then just know the major trends, any interesting diagnoses, et cetera. I know I've been over this last week, so I'm not going to repeat this. So we are going to go ahead and get into the hot seat. I'm looking for volunteers, and I will try to get as many people up as I can. And so if I see Dr. Benda, are you volunteering?
Yes, I am.
All right. Let me just mark my sheet. And do you have a preference which part of your list we work from?
No, it's up to you.
Okay. Tell you what, how about if we start with OB?
Okay.
One thing I'm always careful about is when we're doing these webinars, there's a tendency to look at the first 10 cases or so and never get to the bottom of the list. So I will take a few seconds and sort of scan down to make sure that we don't miss something later on. I'll tell you what, let's actually talk about this case number 23. Have you talked about this on a webinar yet?
No.
Okay. So you can see the screen, correct?
Yes.
Okay, just want to make sure. So my first question in this case, I see that this patient has a history of A1 gestational diabetes and a large for gestational age delivery in a previous pregnancy. When you say LGA delivery, what do you mean?
So LGA is determined at delivery. It's the fetal weight compare over a particular threshold for that week of life. or gestational, or like gestational age at delivery, I guess.
Okay, you say a threshold. What threshold do you use?
So off the top of my head, I believe it's 10th percentile, or for yeah, so it's the 10th cutoff. So 10th percentile, 90th percentile, SGA, LGA.
Okay, and how is that different from macrosomia?
Well, because we can never be 100% sure how large a fetus is in utero, macrosomia is based on ultrasound biometrics and is an estimation of fetal size.
Okay, so would macrosomia also be greater than the 90th percentile?
Oh, I see what you're asking. So, so yes, I believe fetal macrosomia, you're looking at the larger than the 90th percentile as well.
Okay, and in the procedures and treatment column, you say fetal macrosomia risk reduction discussed. What did you discuss?
Yes, so this patient actually had a lot of anxiety regarding her upcoming delivery, given that her baby was so big, she had pushed for a long time, that sort of thing. So we discussed things such as staying within the recommended weight gain for your pregnancy, getting exercise, like 30 minutes of walking most days per week, healthy diet, and then for her in particular, an early glucola to make sure that if she was to develop gestational diabetes, again, that we're keeping on target with it and she's not falling through the cracks and getting a later diagnosis.
When you say an early glucola, what do you mean by early? When would you do it?
So, I mean, ideally, it's as early as you can. For me, it was as early as I could try to nag my patients to get it. So a lot of times they didn't end up getting it to like 20 weeks or sometimes even 24 weeks, which, was could kind of made it less of an early one. But ideally, it's as early as you can, as they come to care and you recognize that this is a possible concern or she has risk factors.
So if a patient comes for a new OB visit at 10 weeks, you would do the early 1 hour at that visit?
I mean, that's a good point. You wouldn't do, for me, I was never worried about doing it too early because they had to get it done at an outside source and it took forever. But typically I would say around 16 weeks, like early, second trimester would be reasonable.
Okay, when somebody does a 1 hour, how is it done?
The patient drinks a 50-gram glucola drink, and then 1 hour later, her blood is taken, and then the result is reported.
Okay, does she have to be prepared in any way as far as her diet?
I actually tell my patients, please don't fast for this, just because, so it does not have to be done fasting. And I have found that my patients who do come fasting don't feel really awesome after it because they can get, nauseous, sweaty. Some people even pass out. So I actually recommend if they are, please eat a little something and please make it be protein rich because you're basically getting like 50 grams of sugar, I don't know what the equivalent is of a soda or anything like that, but just kind of an empty stomach. And a lot of pregnant people don't really feel awesome on that.
What do you use for your cutoff for normal versus abnormal?
I cut it in the middle and I use 135 as my cutoff.
Okay, you said you cut it in the middle. What do you mean?
Yes. So the two different cutoff criteria are 140 versus 130. And so I go averaging both.
So what's the advantage of using a lower value?
A lower value is going to include more people testing that will be included, like categorized as positive in this screening.
Okay, so you'll get more positive test results.
Yes.
Okay, does that mean that you'll have a higher sensitivity?
So sensitivity is looking at the test and seeing how many people of the people that test positive for the test, how many, or other people who have the disease, how many people test positive. So actually, no, that would be lower.
So lowering the cutoff would lower the sensitivity.
Lowering the cutoff would, I'm gonna have to go back to that.
Okay, all right,
just
well, let me
spinning
ask
in
you this.
circles.
It's okay, if you have a patient who does an early 1 hour and the result is elevated,
Yeah.
so you said you use 135, so let's say that their result is 140, then what does this mean?
This means that so having a lower cutoff for your initial screening test means that a greater proportion of people are going to fail the screening test and be included in the subsequent screening.
Okay, yeah, what I mean is if you, yes, really the question I was asking was if you have a specific patient who you test and their result comes back elevated, what does that mean?
It means that they need, so that's a screen. So it sounds like I'm not understanding you correctly. It's the 1 hour glucose is a screening test, and they need to, after that, they need to have a 3 hour, unless their 1 hour result is like 200 or greater, which would just be diagnostic.
Okay, so if they have an early 1 hour and it's elevated, then you would then recommend a 3 hour to rule out gestational diabetes.
Yes.
Okay, so if their 3 hour is abnormal, and this is all done, let's say they showed up in the first trimester, then what does that mean?
Oh, okay. So if she has an early glucola, she has the 3 hour done. So, it in that case, this does get kind of tricky. It's like, was she really just a pre-gestational diabetic? Maybe, so a lot of times you can say pre-gestational versus very early gestational.
So why is gestational diabetes usually later in onset in pregnancy?
Because insulin resistance increases as the pregnancy goes on.
Why does insulin resistance increase as the pregnancy goes on?
I think I'll have to get back to you on that.
Okay, all right. So it's possible, though, that if you have an early 1 hour with an early 3 hour and they're both abnormal, it's possible the patient actually has pre-gestational diabetes and we just didn't know because they'd never been tested.
Yeah.
Tell me, how would that alter your management or your concern? If a patient has pre-gestational diabetes versus a patient who has gestational diabetes, how does that change things for the pregnancy?
Sure. So having a diagnosis of pre-gestational diabetes compared to gestational diabetes is going to increase her risk of fetal malformations, stillbirth, you're too small, too large of a baby, among many other things. So the counseling is slightly different, and obviously if she's pre-diabetic as well, there's a lot of kind of maintenance, labs, and coordination and things that I do if a patient comes in pre-gestational diabetic as opposed to just being failing 1 hour.
Okay, you said there's a lot of things you would do. Give me an example of some things you do for a pre-gestational diabetic during the first trimester of pregnancy.
So she would need baseline laboratory evaluation to include a CMP and I believe now it's a 24-hour urine that is recommended. She would, I believe it's also, obviously we need to figure out if she did not know what her A1C is, I would do an A1C to help with management of counseling of this patient on the risk of fetal malformations. She would definitely need to, in our institution, go to MFM for some early scans to look at the anatomy. And I believe we would also, there's also a possibility of an ophthalmology consult to look at retinopathy. And then our patients at our office get assistance with diabetic education with a nutritionist as well.
Okay. Let me ask you one question about this patient. Let's go back to your patient number 23, because I know I got a little off track here. But with this particular patient, if she asked you, what is the likelihood that I'm going to develop diabetes during my lifetime, what would you tell her?
Unfortunately, having a history of gestational diabetes in a previous pregnancy does confer a pretty high likelihood of developing it later on. And I want to say the number is closer to 50% likelihood that she will develop diabetes at some point in her lifetime.
So how did you, at the end of the pregnancy, how did you rule out whether or not she had pre-gestational diabetes or not? Did you do any testing postpartum?
So postpartum, all of my patients do get an order for a 2-hour glucose tolerance test. But again, I have found that we have a problems with, I maybe only get 50% of them back, to be honest. And this patient always had an issue getting herself to the lab, so she did not complete that.
So wouldn't it be easier to just do a hemoglobin A1C?
Hemoglobin A1C is very convenient for the patient, but from my understanding, the studies still don't really say, how do I say this? They're not recommending it as the preliminary test, which is why we still make all these women suffer through drinking all this glucose.
So in a non-pregnant patient, would you consider a hemoglobin A1C to be an appropriate test for looking for diabetes?
So the literature that I read in the OB and gynecology literature and I shouldn't even have said the word literature, so let's pretend I didn't.
Yeah, I was about to ask, what literature? Tell me, where did that come from?
So my understanding is that the 2-hour glucola is the gold standard that we use for diagnosing, like, say, if you're looking at like a PCOS or metabolic syndrome. Obviously, internists, I see A1Cs coming from the internists all the time. So I'm not familiar with their data. I do see it done a lot. But my understanding is that
okay. I'm going to ask you one last question, and then I'll let you out of the hot seat because I know I've had you in here for a while. The 2-hour is the recommended test for postpartum testing. And there is a reason why. Do you know what the reason is?
Well, so I mean, what I can tell you is that my understanding is that, I don't know, I guess I'm going to have to say no, because I'm like, that's just the test that we do. That's the test that we do outside of pregnancy, whether someone is pre-pregnancy or post-pregnancy, that is the one that we do. So I imagine that it has to have the best accuracy.
So first of all, I want to commend you for one thing that you've done during this time we've been talking is you have stayed with me through all the questions. We've gone several different places, and some of the questions I could tell were things you were less familiar with, okay? But I like the fact that you kept working. You didn't shut down on me. You didn't get into the I don't know, because you had something to offer pretty much for everything. Some of it was more helpful than others. But this is key in the exam. Keep working, keep working. They're going to ask you things that you're not familiar with. So I'll tell you the answer to that last question, and I'm just going to mention 2 or 3 other quick things, and then we're going to move to the next person, okay? The first thing I'm going to tell you, the 2-hour is the preferred test postpartum. And the biggest reason for this is that how likely is it that a postpartum patient who had gestational diabetes will actually have pre-gestational diabetes? The likelihood's pretty low, but the likelihood that the patient could have impaired glucose tolerance or insulin resistance, however you'd like to say it, or pre-diabetes, the likelihood is much higher that they actually will have something like that. And that's important if they have that we diagnose it, because that impacts the counseling even a little bit more from the standpoint of, okay, you've already got changes in your metabolism that are on the road to diabetes, and you need to make changes, lifestyle changes, to try to prevent this from progressing any faster than it already is. And so when you look at the tests, which one is the most accurate for looking for insulin resistance or pre-diabetes? It's the 2-hour. That's going to be the most accurate for that, and that's why that test is preferred. There are other things people have argued about, like if you were just pregnant, will the hemoglobin A1C be accurate because it looks at a longer period of time? I don't know the data on that. I just know that the reason they recommend the 2-hour is because it is the most accurate for diagnosing pre-diabetes, if you will, in addition to being a good way to diagnose diabetes. You mentioned 50% likelihood lifetime risk. I would say in a patient like case 23 who had A1 diabetes in a previous pregnancy in her 20s and now has, again, an abnormal 1-hour, we could debate what the normal 3-hour means in this pregnancy, but she still has some evidence of impaired glucose tolerance. Then, this patient is probably at least 50% lifetime risk to develop diabetes. And that's a really important point, because for her well woman exams, when she's not pregnant, this would be a patient that I would do some type of glucose testing on, probably a hemoglobin A1C if she's not pregnant, because it's easy and it doesn't require any preparation, okay? They don't have to be fasting or anything like that. It's a very easy test for a non-pregnant patient. 2 other things I want to mention. When you lower the cutoff for the 1-hour, you do increase the sensitivity. Okay? It makes it easier to diagnose patients who have the disease. But you also increase the number of false positives. So the concern has always been you have limited resources, and when you lower the cutoff, you diagnose a lot more people, and then you've got to get 3 hours, and it's a lot of, investment in what benefit are you getting. When you lower the cutoff, you may be getting people who have a more milder form, if you will. So that's always the argument back and forth about lowering the cutoff. The other thing I want to mention to you, so as far as an early 1-hour, basically what we're looking for with an early 1-hour is any evidence that the patient actually might have pre-gestational diabetes. So we'll do it as soon as we can. If we see them at 10 weeks, we'll do it at 10 weeks. We're not going to wait. The point is, let's do it as early as we can and see if it's normal or not. We can't really diagnose pre-gestational diabetes until they're postpartum, but we can certainly have a strong suspicion that things are not right, and we can, as you mentioned, maybe introduce some interventions that earlier in pregnancy they're going to be looking for some of the problems associated with pre-gestational diabetes. The last thing I was going to mention to you, we started this whole conversation talking about LGA versus macrosomia. And I want to make sure for everybody listening, because in this case, you list LGA in the antepartum column and you list macrosomia in the treatment column. These are really 2 different criteria. LGA is based on gestational age, and usually we use the 90th percentile as the cutoff. Macrosomia is an absolute value. So it doesn't matter about the gestational age. It's does the fetus exceed a certain value? This case is interesting because the newborn's weight, 4510 grams, exceeds the value that most people use for fetal macrosomia, which is 4,500 grams, okay? If the baby is 4,000 grams, some people use that cutoff for macrosomia, but most people use 4,500 grams. And again, it's irrelevant of the gestational age. So this patient has other things, the 50-pound weight gain, that's certainly not good. There's a lot of things going on here that suggest that this patient potentially is going to be high risk for things like shoulder dystocia, possibly increased risk for fetal malformations. You don't mention obesity, but I'm guessing with this weight gain that her BMI was probably elevated.
I'm going to have to go back and look, but I want to say that she was just overweight. Like, she definitely was not class 3, because I would have put that on there. I think to make it easier to read, I think I was like, I'm just going to take off. It's probably like class 1.
Yeah, so that's again, just a lot of things to think about with this particular case mainly related to the metabolic issues around blood sugar. That's really what this case makes me think about. And you did mention increased risk of birth defects. I didn't ask you, but do anticipate being asked what kind of birth defects are associated with diabetes and pregnancy. I'm not going to go into that right now because I've used a lot of time. Thank you. I'm going to let you out of the hot seat. Any questions from you before I let you go?
No, thank you so much.
All right, nice job. Okay, I'm going to, now what I'm going to do tonight, at the end, I'm going to come back and answer any questions. So right now I'm going to assume that if you have your hand up, you're volunteering. I know we have multiple people. Dr. Jones, are you there?
How you doing?
Good. Can I go to you now?
Sure.
All right. And do you have a preference which list we look at?
I don't.
I'll tell you what, let's, how about if we go to GYN, just kind of moving it around, going to different areas. Just one second. I'll tell you what, let's talk about case number 34.
Okay.
So how did you make the diagnosis of a missed AB?
For this particular patient, she had an ultrasound that showed a gestational sac with a fetus without a heartbeat.
Okay. So does seeing a fetus without a heartbeat automatically guarantee that this is a missed AB?
No.
So how would you know that the diagnosis is correct, especially when you're thinking about possibly doing some type of intervention that would lead to losing the pregnancy if it's a normal pregnancy?
There's specific criteria that we use. And so for this particular patient, her gestational sac was large. It was greater than 2.5 centimeters. Her crown rump length was also measuring greater than 7 millimeters. And she had previously had shown an ultrasound with a heartbeat. And in this follow-up ultrasound, there was none.
Okay, so serial ultrasound with a heartbeat that then disappears would be confirmation. I would agree with that. Can you diagnose a missed AB with a single ultrasound?
Yes, if the measurements are meeting the criteria for gestational sac with a yolk sac and a fetus. Well, I guess no, you would need a follow-up ultrasound to confirm.
In this case, once you had confirmed it, what did you tell the patient she should do?
Well, after telling her the diagnosis, I basically offered her expectant management versus medical management versus surgical management, and the patient opted for surgical management.
How big of a difference is there in the success rate for complete passage between expectant medical management and surgical management?
Well, for surgical management, the procedure is pretty accurate once it's completed. The pregnancy is complete. With
Are you
medical,
telling me that, are you telling me that surgical management is 100%?
well, no, not 100%, but it's probably the most accurate form of um, ending the pregnancy. And then
Okay, so
with,
you would say that the likelihood of complete management in a single episode with surgery is going to be greater than medical or expectant management. That's what you meant.
yes,
Okay. What about for medical management and expectant management? How likely is it that a patient will successfully pass the pregnancy with each of those without requiring any additional intervention?
I'm not exactly sure the specific percentage, but depending on the gestational age, medical management would be more accurate or more successful than expectant management, probably greater than 80%.
Have you ever had a patient who really didn't want to do anything? They just wanted to let things happen?
Yes.
When a patient chooses that, how long do you think it'll take?
It depends. If they're having symptoms when I see them in the office, it can take anywhere from a couple of days to weeks.
How long would you let them go before you'd tell them that you think they needed to do something?
I don't really have a specific timeline. I usually try to reassess symptoms every week or so to see if they're having worsening bleeding or any signs or symptoms of infection. But I do typically counsel my patients that, I'm not going to let this go. We're not going to let this go forever. We can give it some time, up to a month or so, and then reevaluate the plan.
So if they've been 3 or 4 weeks, then you suggest they should think about doing something else.
I would have a conversation with them.
Okay. Are there any contraindications to medical management?
For medical management, I would definitely, if the patient is not necessarily reliable, and I was worried that I wouldn't necessarily have a follow up with them, I would be concerned with that. If they, I'm drawing a blank. Um, if I'm concerned with a bleeding risk, if they have a significant anemia. I know there's more, but I'm drawing a blank. I'm sorry.
Okay. So do you do medical management if a patient wants to do that?
I can.
How would you do it?
I typically prescribe misoprostol, 600 to 800 micrograms, and then have the patient follow up if she hasn't had any bleeding within 24 hours.
Okay. And if the patient follows up and hasn't had any passage or heavy bleeding within 24 hours, then what would you do?
You can repeat the dose.
Okay. Now, what do you tell the patient regarding follow-up if they have what appears to be a miscarriage after medical treatment?
I typically have the patient follow up in the office in a week or two just to kind of follow up on how they're feeling and what's going on, assess their bleeding. If they want, they can have a follow up ultrasound as well. But there's no standard follow up appointment requirement.
Okay. So if they come in, you won't make them get an ultrasound, but that's available if they need it, I think is what you said, right?
Yes.
And
If they
would you
have
do anything else?
confirmation, if they had confirmation that they had bleeding, um, if they typically they probably would have had a blood test previously measuring their pregnancy hormone, and so I may repeat a beta if they don't want an ultrasound just to see if that number is downtrending.
Okay. You mentioned you give misoprostol, right?
Yes.
Is that the most effective method of medical management of a missed AB?
It's not. The most effective would be mifepristone with misoprostol. Unfortunately, we don't have that available at my hospital.
Okay. Now, in this particular case, you took the patient to the operating room, and I noticed that you mentioned in the complications brisk uterine bleeding.
Mhm.
Why was she bleeding so much?
To be honest, I'm not exactly sure. I think it might have just been with the removal of the pregnancy, low tone, and so there was an increase in bleeding. I did some uterine massage and gave her uterotonic, and she firmed up nicely.
What uterotonic did you give her?
I ended up giving her rectal misoprostol.
Okay. And the bleeding resolved, the tone firmed up, and she didn't have any complications.
She actually went home after the procedure.
Now, when the bleeding was happening, obviously the diagnosis that you made is one possibility, that she could have decreased uterine tone with evacuation of the pregnancy. What were the other possibilities that you were thinking about when you saw this more than expected bleeding?
With a blind instrumentation, I'm always worried that there's a possibility of a perforation or basically a perforation, and whether or not I went through the uterus or one of the vessels.
Okay, anything else?
I guess there's a potential that if the ultrasound was inaccurate, that it was a different type of pregnancy, a molar pregnancy, and that could lead to significant bleeding as well.
Tell me, how would you diagnose a molar pregnancy?
Several different ways, of course, with pathology, and you can also diagnose it based off of ultrasound findings. Typically on the ultrasound for a mole, it would be hydropic, kind of like a cluster of grapes on imaging.
Is that cluster of grapes, is that a complete mole or a partial mole or both of them?
That would be a complete mole.
Okay, what would a partial mole look like?
Oftentimes we find fetal tissue in a partial mole. So what appears to be like a mole.
So it might be harder to tell apart from the missed AB.
Yes.
Okay. Which one is worse? A partial mole or a complete mole?
In regards to?
Well, that's a good question as well. After you tell me which one is worse, I'll ask you why. That's very perceptive. Yes.
Let me think about this. So regards to potential for malignancy.
Let me ask you a question. Yeah, what's the worst case scenario that you can think of with a molar pregnancy?
Malignancy or like choriocarcinoma. And
invasive disease, right? Mm-hmm. And even worse, metastatic invasive disease. So which is more likely to have that, a complete mole or a partial mole?
A complete mole.
Yeah, so even if you weren't, that question might have caught you off guard. I'm giving you a little feedback now. Okay. In the exam, step back for a second and just think about, which one of these, what's the worst case? The worst case is going to be invasive disease and metastatic invasive disease. And, that's more likely with a complete mole. We all kind of know that from medical school even. And so I would pick that one. I think both of them are, less than ideal, but the one that's going to potentially have more longer term ramifications would be the complete mole, because the percentage of cases that are going to have invasive disease is going to be higher. Make sense?
Yes.
Okay, now, really quick, I'm almost done here, but if this patient on her surgical pathology, if it did come back and you got pathology that said complete mole, what would you do? So now she's post-op, she's doing fine, and you get this pathology back. What would you do?
I would have her return for a beta after the procedure, beta HCG
okay.
level.
And how would you interpret the results of that beta? How would that help you?
I would look to see if the value was downtrending or increasing.
And which would you prefer to talk about, increasing or downtrending?
Well, I would be worried if the value was increasing after surgery, and then I would consider treatment. Or
okay.
Wait, yeah.
So, I was really kind of giving you a fork in the road, and you picked the harder one of the two, which I respect. Okay. So now we could talk about, okay, so if it is increasing, then what will you do next? Okay. Let me do this. For the moment, what I'm going to do is I'm going to actually just ask you this because I think this is important. If the value is going down, then what will you do with that?
I would follow it down to 0, and then
Okay. And
continue
then
to follow that value after, just to make sure that it didn't either plateau or increase afterwards.
Okay. How long would you follow it once it got down to 0?
I'm not exactly sure how long, probably a month. I'll take a guess with that.
Okay. And what else would you do besides following the HCG?
I would make sure that the patient had adequate birth control, because I wouldn't recommend pregnancy at that time either. I think that's pretty much it. I wouldn't necessarily do serial ultrasounds.
Okay. Now, when you say adequate birth control, so if the patient strongly desired a pregnancy, when would you tell her that she could go off her birth control and try to get pregnant?
Specifically after a molar pregnancy, I would wait several months.
Okay. 2, 4, 6, 12?
6+ months.
Okay. So I'll tell you, this is where it gets a little bit tricky. It depends whether it was a partial mole or a complete mole. And it depends on whether the case was very straightforward or not. But in the most straightforward case, let's say you did this surgery and your pathology said complete mole, and you followed her HCG and it was going down and it became undetectable. In the old days, we would have said we're going to follow her for 12 months. But nowadays, nobody follows anybody for 12 months. If they have that very straightforward scenario where it goes down, becomes undetectable, then usually at that point, what will happen is the patient will be followed usually for a couple of weeks, usually 3 weeks of undetectable. And then at that point in time, with a complete mole, 3 months would be a minimum, and with a partial mole, 1 month. Okay. And then you could discontinue monitoring the patient at that point in time. This is the minimum. So a lot of people will say 6 months. Okay, it's a little bit more conservative. I think 12 months, unless we're talking about a high-risk patient who's been treated for invasive disease, that's really not going to be what most people would do today. And so the issue about pregnancy, once a patient does decide to try to conceive, we do need to remember to mention that we would just tell them that they need to come back for early ultrasound evaluation with their next pregnancy. Okay. So, as soon as they think they're pregnant, we want them to call so we can get a first trimester ultrasound to look for signs of a normal intrauterine pregnancy. Okay. Because although the risk of a molar pregnancy in general is low, the risk of a recurrent mole in a future pregnancy is about 10 times the baseline risk. So it's not super high because the original risk was pretty low, but 10 times increased risk is enough to warrant close supervision with future pregnancies. Okay?
Yes.
So I do want to mention a couple things that we just talked about for everybody listening. All the questions that I asked are basically material that's covered in ACOG's practice bulletin on early pregnancy loss. All the questions that I asked are definitely fair game and would be considered relatively, I would say, basic to moderately difficult questions. We really didn't get too far into the weeds. The one thing that I find a lot of people are struggling with is the criteria for a missed AB. And Dr. Jones, I don't know, do you do your own ultrasounds, or do you have an ultrasound tech or radiology office that you have doing the ultrasounds?
We have a tech and a radiologist.
So you really don't do the probe. You're not doing the images yourself.
No.
Okay, and that's very common. That's what I find today. And so that when you're not doing the images yourself, the criteria kind of lose some of their meaning because you're not looking at the pictures real time. But the key here to understand is that there are different ways we can make this diagnosis. One of the ways is if we see a fetal pole And you mentioned 7 millimeters, and that's the right number. If the fetal pole measures 7 millimeters or more, and there's no cardiac activity, that is diagnostic, that we don't need to repeat an ultrasound, although we do a lot of times because patients are struggling to, grasp the diagnosis. But the 7 millimeters or more with no cardiac activity, that's diagnostic. There should be cardiac activity at that point. Now, where people get also confused is they start to talk about the sac diameter. You talked about the mean sac diameter. This is important for an anembryonic gestation, meaning a blighted ovum. If you have a sac that's 25 millimeters or more with no yolk sac, then this is also diagnostic of a missed AB, but it's an anembryonic gestation, not a fetal loss. Okay, so these criteria, again, are all in that practice bulletin. They are fairly important. I will just mention 2 other things that I think we talked about. A lot of people don't realize that the success rates for expectant management and medical management are pretty good, and they're pretty similar. About 80% for expectant management, and about 85 to 87% for medical management, and then 95+% for surgical management, but definitely not 100%. We've all seen the patient who had a DNC and had to have a repeat procedure for retained products. So just keep that in the back of your mind. It's not 100%. The key thing about expectant management is it takes a lot longer. Medical management and surgical management are going to be much quicker. With expectant management, according to ACOG in their practice bulletin, it could be up to 8 weeks for complete passage. And if a patient's otherwise stable without signs of infection, then that would be reasonable to let the patient, if they're motivated, to let them go even up to 8 weeks, and that's where you get to 80% passage. Now, we were talking about contraindications to medical management. So any patient, of course, who's actively hemorrhaging, which really would be an incomplete AB, they're not a candidate necessarily. Any patient with a severe anemia, and severe anemia, definitely anything, hemoglobin less than 5, absolutely. The problem here is that you send a patient out and, you're going to have, they have bleeding of a normal amount and they're going to be into a crisis. And 5 is an extreme example. I would argue really anybody with a hemoglobin less than 7, we probably need to be thinking about this. And then anybody with evidence of infection also would be a bad candidate for expectant or medical management. So these are just a few of the kind of major contraindications to think about there. So Dr. Jones, before I let you out of the hot seat, do you have any questions for me?
So you said you left me with like a fork in the road, so that I'm sure will happen.
Oh, yeah, it does. And, the bottom line is when you reach a fork in the road, so I asked you how you would manage the HCG follow-up. So I think you have to be prepared. They're going to ask for both sides, but I would pick what you're most comfortable talking about first. Okay. Mm-hmm. So, because I think what that does, it starts you off on a good path. You get building a little confidence. So for instance, with that molar pregnancy and follow-up, I'd say, well, ideally after the surgery, the HCG would be going down. And if it was, I would follow it until it's undetectable, wanting to make sure it didn't plateau. I say that on purpose because I'm hoping they'll ask me, what if it plateaus? And then I could, because that's something I'd feel comfortable talking about. But okay, hoping it goes to undetectable without plateauing. Then I'd check 2 more just to make sure that it's not, that it's undetectable, remaining undetectable. And then I'd follow the patient, depending on whether it's complete or partial mole, for a period of time before I would stop surveillance. And the way I kind of said that leaves the question, well, how long would you follow them? And what's the difference between, so you're kind of setting the examiner up to ask you predictable questions. And it's easier if you practice this. Then, of course, what they're going to do is say, oh, okay, but what if it goes up? And okay, then we'll talk about that side of the equation and the evaluation for a persistent mole or invasive disease. And that's also a great discussion. So, but again, what I always recommend to people is if they leave you open, pick the side of the equation you know best, because it gives you a little confidence. You can kind of lay out something really clear and then know you're going to go back to the other part, and you'll work through that until you reach a point where you have nothing else to say. Always work from what you do know to what you don't know. You want to get as much partial credit as you can. And when you get to where you don't know, then at that where you really don't know, at that point, you either have 2 choices. You can say, this is something I don't know, I'm sorry. Or you can say, I'm not completely sure. My feeling on this is that the answer is X, Y, or Z. And when I say that, you're kind of just being honest. You're telling the examiner, I'm not 100% sure. We've reached kind of the end of my knowledge on this, but based on my experience and what I do know, I'm thinking it's going to be X, Y, or Z. And you will get some partial credit if you're right. You have to be careful not to say that all the time. If everything they ask you is, well, I'm not really sure, I'm thinking it would probably be, then what happens is all those qualifiers start to sound like a lack of confidence. Does that make sense?
Yeah.
Yeah, but bottom line, if they give you a fork in the road, I recommend always pick the side that you know best to build your confidence and to get it out there so that you've done something good that the examiner can say, okay, they've got that. And then, expect they're going to go back to the other side of the equation. Okay?
Yeah. Thank you.
Yeah, any other questions?
Not right now.
Okay, I want to commend you, just like with Dr. Benda. You just kept working as we went. And I'm telling you guys, this is so important to make yourself continue to participate in the exam. So to keep the I don't know as, far down the discussion as possible, if you can, by volunteering what you do know and not being freaked out by what you don't know. And I want you guys, I'm glad to see all of you in these webinars early, because the more practice you get, the better off it's going to be. All right, Dr. Jones, I'm going to let you out of the hot seat. We're going to get another person in, okay? All right, I'm going to go to Dr. Herzlich. Are you there?
Yes, hi, I'm here.
All right, I'm going to come to you now if that's okay.
Yes.
And do you have a preference which list we look at?
We can do office. I think we did OB and
Yeah,
GYN.
okay. Yeah, no, I like that. That's good. Let me just get your office list. Oh, let's talk about case 36.
Okay.
So I see it's a well woman exam, and I see the patient's 40 years old. And when the diagnostic procedures column says diagnostic testing, what diagnostic testing are you talking about?
So this lady came just for a regular annual check. Nothing like no complaints or anything that she was bothered with, except for her BMI, which is class 3 obesity. So I was concerned about metabolic syndrome, which I counseled her about. And I did the routine test, which included test for lipidemia, so lipid panel, triglyceride, LDL, HDL, cholesterol. I also tested her for diabetes. I'm trying to think if I did anything else for the labs. I think that was it. Yeah.
You mentioned concern for metabolic syndrome. What are the diagnostic criteria for metabolic syndrome?
So metabolic syndrome, that will include measurements of waist circumference, which will be above 88 centimeters, which is 35 inches. So that will be one. It will be triglyceride above 150, HDL below 50. Then glucose, I believe, the glucose, I believe it's fasting, which is above 100. And yeah, that's the 5. Yeah, so there are 5 criteria and we need 3 out of the 5.
Did you mention blood pressure?
No, I did not. So blood pressure is one of them. It's any blood pressure of systolic above 130 or diastolic above 85.
Okay. All right. Now, in this case, I see that you started the patient on statins. How did you decide to start her on a statin?
So based on her lipid panel, she had elevated cholesterol and elevated LDL. I started her on low potency statins. There is kind of, I mean, usually I start them on low potency, and if it's anywhere like when there is severe hyperlipidemia, I of course co-manage it with PCP. So I just recommended her low potency statins and then referred her for her primary care physician for continuous of this of management.
Okay, so you base the recommendation for a statin on the value of her LDL cholesterol?
Yes.
So how high does the LDL have to be for you to recommend the patient start on a statin?
So LDL should be, in order to start, I mean, first of all, we start with counseling about lifestyle and diet. But then in terms of starting on medications, above 1, I believe about 150. I'm not sure.
Okay. Now, do you treat a lot of patients with elevated cholesterol in your practice?
No, usually my patients will have their primary care physician taking care of that, but this particular patient was not really going to other doctors, so she kind of chose me as her primary care. So it's pretty unusual for me to do that. Usually most of my patients are being well managed by their primary care physicians.
Do you always choose statins, or do you sometimes choose other medications for elevated cholesterol?
To be honest, I don't have a lot of experience of starting medication for this, so just statins are my experience. I usually do counsel them about more balanced diet and healthy lifestyle with exercise. I usually refer to the.
Okay, so here's the deal. Did you notice how as soon as I saw this case, I immediately was, oh, let's talk about case 36. I almost got like a little bit excited when I saw this case. Did you notice that when we were starting?
Yes.
Yeah. Okay, here's why. You're exactly right that there are a lot of OBGYNs, a lot of patients where the OBGYN might be their only doctor. And this is why we are expected to know a little bit about some of the most common primary care issues. And when we think about cholesterol, this is a risk factor for heart disease. Well, guess what? What's the most common cause of death for women in the United States? Heart disease. So this is a very important primary care issue that we expected to know a little bit about. Many of us, years ago, we trained in a system where we looked at the values on the lipid panel and we used the values to decide whether to put a patient on medication. But nowadays, the way this would usually be done, we look at the patient's risk over the next 10 years or over the next 30 years for heart disease. Usually we start with their 10-year risk, and we can do this using a simple calculator that's on the internet that we put in information about the patient. It's not difficult information. Some of it is the values from the lipid panel, but things like, do they have diabetes? And there's other things that we have to enter in there. And it gives us their estimated 10-year risk for cardiovascular disease. And then based upon that level of risk, we decide whether to start them on a statin or whether to focus on lifestyle modification and repeat testing, okay? So the cutoff for starting a patient on medication would usually be considered greater than 10% 10-year risk for cardiovascular disease. And if they're less than 5%, then we would pretty much always defer to lifestyle modification and repeat testing no sooner than 6 months, often in a year. If they're between 5 to 10%, this is kind of a gray area where it's really shared decision making, okay? Where we talk to the patient about the risks and, also the risks and benefits of the medication. So since you have this case on your list, I want you to look at this, study on this topic a little bit. Even if this wasn't the way that you did it, I would take this patient's information and put it into a calculator. There are multiple different ones. The most common one that I would think is used today is called the pooled cohort equation. And if you go on something like UpToDate and search hypercholesterolemia, you're looking for, remember this, you're looking for primary prevention. What I mean is this patient doesn't already have heart disease. So we're trying to prevent it. If you have somebody who already has heart disease, it's a totally different thing. And that's something we don't manage. That would be the cardiologist. So key thing, look at for the risk stratification at the calculator, put this patient's information in just so you have an idea. If this patient's risk is in the 5 to 10% range, then what you did is totally reasonable. If it's less than 5%, then it's a little bit aggressive. And if it's greater than 10%, then it's absolutely necessary. So do you see how this is important, just to kind of have an idea? So study up a little bit so that you can talk about it with the examiner if they ask, okay?
Mm-hmm.
Also, the LDL value, there is an LDL value at which you wouldn't need to do the calculated risk, and that's 190. If it's greater than 190, that's a very high LDL level. In fact, this is another question I didn't ask you, but I'm going to ask you now. If you wanted this patient's cholesterol, LDL, if they said, what is a good value, what would you tell them? What would you like it to be below?
I believe it's 120.
So the old number we used to use was 130, but because this patient actually has risk factors, and nowadays most of the labs are reporting out less than 100, which is the more current guideline. So we'd like LDL to be less than 100, okay? Now the cholesterol, the total cholesterol, sometimes that can be important, sometimes not. And here's what I mean by this. Some patients will have a slightly elevated total cholesterol, but when you look at the specific values, their HDL is very high. And that's part of the reason their total cholesterol is elevated. If you have a high HDL, is that good or bad?
High HDL is good.
That is good, exactly. So sometimes a high total cholesterol is not actually a problem. Now, there is a level at which we would like to see the HDL get above. Do you know what that number is?
It should be above 50. I mean, that's
so above 50 would be for a normal value, and for a woman, and for to lower her risk, we'd like to see it above 60. That would be even better, 60. Okay. So do a little bit of reading on this topic, because I think the examiners, if you get an office examiner who has any primary care experience, which a lot of them do because that's why they're doing office in the exam, they'll see this case and they'll be like, oh, this is great. Let's just, in just a few minutes, they'll figure out whether you know anything about cholesterol or not. And it's not as much about specifically this patient, because there's a lot of shared decision making, and you could probably argue based on her risk factors that even if her risk is low, her long-term risk is higher. It's not the usual way, but again, the point is, I don't think what you did in this case is wrong. I just want you to be able to back it up with a good understanding of cholesterol management, okay?
Yeah, thank you. I'll
But
prepare
by
it.
the way, and usually when we do start people on statins, we usually start with a moderate potency or moderate dose statin. So that's another thing. I would shy away from the low potency. If you're going to start them, usually we start them with a moderate potency or moderate dose statin. I don't think you have to know, for everybody listening, I don't think you have to know all the statins and where they fall, but certainly if you're prescribing a statin, you should have an idea which statin you might give and where does it fall in the range. Okay?
Yeah. Yes. Thank you so
Any
much.
Any questions for me before I let you out of the hot seat?
No, that was great.
Okay, good. So I'm going to let you out of the hot seat here. Now, what I'm going to do is I want to find out if there are any questions so far from tonight. And if you have any questions, if you will click the raise a hand feature. Dr. Benda, do you have a question?
I do not. Is my hand still
Okay.
raised? I'm sorry.
It is. Sorry about that. Okay, let me see if there are any other questions. Okay. So, Dr. Lanasa, are you there?
Yeah,
Dr.
I'm here.
Lanasa, are you?
I'm here.
So you were volunteering earlier, right?
Yeah. Mm-hmm.
Okay, you were the next person on my list. Tonight we got a little bogged down. I didn't get through as many as I usually will. The next time I'm doing a webinar, which I think I'm the 31st of August, I'll get you in the hot seat first, okay?
Oh, goodness, no problem. Thanks, though.
Okay, great. So with that, seeing that we are a little bit past 9:30, I'm going to go ahead and wrap it up for tonight. And I do want to remind everybody there will be a structured case webinar tomorrow night, Wednesday night, so please join us then. And thank you very much for participating.